for all the people with conditions, challenges to reach health facilities, and thus a very important task for community health workers to provide services to these remote populations. Next click, please. And yes, Lesotho also, since a long time, has an existing community health worker system, mainly focusing on HIV and maternal diseases, and still working mostly paper-based. So this is a bit the setting where then we came in. Next slide, please. Yes, and now, as you all know, all over the world, also in Lesotho, the prevalence of chronic conditions or non-communicable diseases such as diabetes and hypertension are increasing. And because so far there is no care available for these conditions, at the community level, we came up with the Combacol model of care, as we called it, that has as a cornerstone basically the task shifting of primary level NCD care to community health workers. And we did this using CHT, which is why we are here today. Next click, or 2 clicks maybe. So what we did, we set up our application and then first piloted the whole intervention in 10 villages, which we call the pilot cohort study, and then refined it and then took it to a larger cohort of roughly 100 villages, of which we are going to present the results to you today. Next slide. Yeah, maybe you can give it a few clicks now because there are some animations on it. So here, just because as said, we are also working in a clinical trial setting. We didn't just want to implement an intervention, but we also wanted to assess its effectiveness. And we did this by running cluster randomized trials within our cohort. So before you have heard, we had about 100 villages. And then we assigned different interventions to half of the villages, which we called control and intervention. So in all the villages, the community health worker received a CHT application that would guide them through blood pressure and diabetes screening and diagnosis, lifestyle counseling and referral services. So people with a condition would be referred to a healthcare worker in a facility, kind of as the basis, or how it's usually done in other NCD projects at the community level. And then in addition to this, in 50 villages, we also included treatment components in our algorithm. So the community health workers in these villages were able to prescribe antihypertensive, anti-diabetic medication, and also based on cardiovascular risk assessment, aspirin or lipid lowering drugs, and provide treatment monitoring and support for people with complicated diseases, for example, for people who require insulin or other medication. And basically the overall aim or study question that we had was to assess whether an intervention with drug prescription by community health worker guided through CHT would lead to superior blood pressure and blood sugar control compared to just a control approach with referral. Next slide. And yeah, also give it 2 clicks. Sorry, animations are not great if you're not navigating yourself. So basically, we started out by setting up our cohort in early 2023. So registering all the people living in the villages, and then step by step, we introduced the different interventions. So a few months after this, the diabetes intervention, and then later on the hypertension intervention. And basically, since September 2023, we now have this integrated intervention for diabetes and hypertension ongoing. Next slide. Yeah. Very good. Yeah, here just a few pictures. So initially, as said, the community health worker system was existing, but still it was quite difficult to find all the villages to recruit the community health workers in villages where there was nobody. So just give it a few clicks. It's not much content, but just a few nice pictures. So yeah, another one maybe. So you see a lot of community gatherings that had to be done to elect the community health workers. And then please continue. Next slide is just a few impressions from our training. So we handed out glucometers, blood pressure devices, and then all the equipment that was required for providing the care. And most importantly, obviously the tablet with CHT on it that would enable them then to follow all the rather complex algorithms for diagnosis and care. Next slide. Here just an overview and maybe give it another 2 clicks of our cohort enrollment so that you have an impression. So currently we have about 15,000 participants that are in the cohort. Over time it was all over the month it was about 16,000, and then we had a lot of people moving in and moving out. So, and here maybe also a bit special, we really aim to have the whole village population covered, so to ensure that community health workers are not just going to, households that are maybe close or people that they know that have a problem, but that we really have the full picture so that we also can gather relevant risk factor data, for example, and better understand the overall dynamics of these conditions in the population. Next slide. Yeah. And here just a map. So you see the blue and the red dots are our villages across the 2 districts, and we select them randomly among all villages. So they're spread out all over the place. Next slide. Yeah, also give it a few clicks. So basically, we needed to represent the whole health system hierarchy. This was quite easy with CHT as this was already inbuilt. So we used district, facility, village level, then going to household and clients. As said, we enrolled basically the whole population of all the villages. We needed algorithms that were different between intervention and control villages for screening, diagnosis, and then treatment components. And because we also needed it for research endpoints, we need to make sure that we got data in time, and that we also had a rigorous safety monitoring that we could then, for example, report to ethics committee and have reliable data within a study setting. Next slide. So basically, what were our main challenges? I think one of them was definitely the integration also with research data collection, because it just makes it a bit more complicated. You don't only have to consider clinical conditions, but you also have to consider study windows, and then also including the treatment component in chronic care was also quite complex, because you can imagine that these people, they need monitoring, treatment adjustment, and so on over time. So you need a longitudinal follow-up, and you need to have access to many variables across different forms, because obviously if you measure a blood pressure one day and then you go back after 1 week, you still the decision that you will make on that day will depend on the previous measurements. Also, you have to capture acute events and translate them into chronic statuses. So, for example, if somebody has a myocardial infarction, this will have influence on the treatment over a lifetime. So you have to consider that from the event on, then also in all subsequent forms. Maybe give it 2 more clicks. Yes, also there are a multitude of outcomes like allergies, pregnancies, and so on that will accumulate over time and make your thing more and more complicated. And then also our model was designed to allow participants to freely move between facility and community-based care. So also there it was quite unpredictable then how the individual participant would behave and what kind of treatment would then be needed at a certain time point. Please, next slide. And also again, yeah, maybe just click to the end. So basically here, this is now a bit the flow, how we imagined it in the beginning. So we thought, okay, we create our client, we get the study consent, we do a baseline data collection that we also used as a pre-screening to determine who was eligible for then a measurement, like a hypertension screening measurement, and then people would go through the different steps. So first the screening visit, if they had an elevated value, they would have a confirmation visit, then would have a treatment initiation, then would have a treatment monitoring, and then basically be monitored over time. But then during our pilot study, we realized that most patients, they don't actually behave the way that we expected them to behave. So the typical example, people stop taking their medication. So you cannot just assume that they will just remain in the treatment monitoring loop, but maybe they will go back to treatment initiation, or they even go back to the screening, or some people directly after the screening, they have very high values, so they directly need to initiate treatment. So we realized that such a linear approach, even though this would be logical, doesn't make sense in real world. So we had to adapt this then for our main application. Next slide. So what did we do then? So we started, the start of our flow was still the same, but then thereafter we had to do quite a radical change. So instead of having all these different forms that had different functionalities, we merged all of them into one quite large form that was flexible enough to accommodate for any kind of situation. So no matter whether the patient was already diagnosed with a disease, whether the patient was taking medication, stopped the medication, had an allergy or whatever, we had the same form that would use all this information with a lot of skip logic so that we could give the correct treatment advice at any time point independent of what happened before. Please, the next 2 clicks. And then we just calculated several clinical statuses, like a diagnostic status or a treatment status, that we then used to retrigger basically the same task, but obviously depending on what data was entered, the task would then have kind of various pathways within this one form. And then because, as mentioned before, of the study outcomes, we also had to consider some study statuses to make sure that we get everything collected at the right point. Next slide. So also, as I said before, for chronic care, you always need to have access to previously collected data. So initially in our pilot flow, we defined for each task a set of variables that we would take to the next form. But then again, because patient trajectories were just so flexible, we realized that it is basically impossible to foresee which kind of variables would be required in which task. So we defined a larger pool of all possible variables that could ever be needed for any kind of clinical decision making, and then just preloaded this whole set of variable into each form. Maybe 3 more clicks. So basically, we just then use the same preloading method for all the forms, and it would always loop through all the forms chronologically. So always going back to the form that was submitted before, check if a value is available. If no value is available, go back through all the forms ever submitted so that we would have access to all data that is of relevance at any time point. Next slide. Oh yeah. Well, that's a side note, but there also you need to be a bit careful because sometimes we then had variables that were not, you couldn't change them in every form. Maybe you just enter the value at baseline. For example, you say at baseline somebody has a heart failure, but then this question doesn't come up every time. So using this method, then you would always replicate your data entry errors that were made in the beginning. So we had to introduce a workaround which we called correction form that would allow the management team to specifically change some values that would not appear anymore in the subsequent forms so that we could get rid of the data entries and avoid them accumulating over time. Yeah, next slide. And one other thing that was also important for us is because now we had these large forms and we had a lot of measurements that we didn't want to do every time. So maybe give it another few clicks. So you can imagine, for example, weight measurements and so on. We defined, for example, we want to have a weight measurement every month. But then if somebody has a form within a week, it doesn't make sense to always measure this, or also dates for trial enrollment or the time of the last visit were relevant for then our skip logic within the forms. So we also use these dates as preload so that we could make the forms more streamlined and didn't have to re-ask all the questions every time. And I think also this was quite important for us to have it a bit more efficient and avoid collection of unnecessary data. But this was also one of our biggest challenges after the upgrade to version 4, because as you all know, after version 4, some of the date formatting changed and then a lot of our logic didn't work anymore. So we had quite a bit of headaches there, which we managed to resolve after some time. Good. Next slide. Yeah, so here also, give it 2 more clicks. Basically, what we did is that every week we did a full database download, processed all the data in R to produce dashboards and line listings for our study team, then to monitor safety data and study data, so to ensure that we have everything covered there for research and safety purposes, while at the same time also our community health workers would still attend the meetings with the routine facility staff for drug refills, to also make sure that it is not now all done just in a study setting, but also would function in a routine setting. Next slide. And here just a few results. So you see that overall we had about 8,000 participants that were eligible for screening, and after about 6 months or 1 year, we had roughly 98% of them screened. And I think here also this is quite a strong point now for community health systems, because obviously you could never reach such a coverage by just referring participants to a health facility, because many will never go, and also outreach activities, usually you find maybe half, if you're lucky, half of the people in the village, because most of them are working in the fields and so on. So I think here our community health workers did really do an amazing job to really get an exceptionally high screening coverage. And then you see that we found a hypertension prevalence of roughly 17%, which was more or less expected. Of those, about 75% of them were already on treatment at baseline, and of those, about 75% controlled. So overall, we found a control rate of about 50% among all people with hypertension. Next slide. And then here, just some preliminary outcomes now from our intervention. So you know that half of our people are living in control villages where no drugs are offered by the community health workers, while in the intervention villages, community health workers are offering medications. And after 1 year, we see that about half of the people with hypertension are in care by the community health workers, while 1/4 is still in facility care, maybe because they have more complicated disease or because they prefer to go there, and about 1/4 did not require treatment anymore. So because maybe they changed their lifestyle or because of a misdiagnosis at baseline. And also here, I think an important message for other people considering such interventions is that, yeah, it's probably about half of the people with hypertension that we could actually manage to take care of them at the community level using an approach like we used it. Next slide. And maybe also a few clicks. So in addition to now the clinical intervention, we also conducted a brief usability assessment of CHT for the use of delivering chronic disease care. Overall, we had quite a good outcome on our system usability score. The only point that was a bit troublesome is that most village health workers said that it required quite some training efforts to get going. I don't think that this is mainly related now to CHT itself, but rather to the complex workflows that we used. And about 98%, so basically all of them, said that it was quite easy to diagnose somebody with hypertension or diabetes with the support of CHT, while only 2/3 of them would assume that it would be easy or possible for them to do with CHT. So again, I think hypertension diabetes care is maybe a bit more complex than other services usually provided by community health workers, but definitely feasible with CHT, maybe a bit less feasible without the digital support. And yes, in Lesotho, we still have some challenges with network and electricity. And also one of our downsides, also maybe some lessons for other people who want to do research within an implementation project. Also make sure that you don't collect too much research data, otherwise you will tire your community health workers if they have to respond to too many questions. Good. Next slide. And yeah, give it a few clicks. So I think for our main lessons now for chronic disease care, using CHT or clinical decision support in general, the linear flow just doesn't work in practice. You need large, flexible forms that allows your community health workers to be ready for any kind of situation. You need to have access to previously collected data. We would recommend to do this with a method that is flexible enough, so not each time defining the variables for each task, but really choose a set of variables that you know that they will be sufficient for the lifetime of your project. You have to be careful with data entry errors if you preload because they can't replicate. So maybe you also need to work around use timestamps to avoid redundant questions if you have repeating forms. And then I think one more click. Yeah, also we didn't touch upon this, but yeah, we translated the whole application was translated from English into Lesotho, the local language. We always provided the two languages, and we used rather rigid instructions, so the app would not give a lot of freedom now, for example, for choosing the dose of the medication. So it was all predefined by CHT, which I think was quite well appreciated by our community health workers, as otherwise it wouldn't have been possible for them to really go to that level of complexity of care. And I think that was it. One more click. I think we're at the end. Yeah, that was it. Thank you very much.
All right. Yeah, thanks, Felix, for that insightful presentation. So I'm not sure if anyone has a question. They can unmute. I can see community members are appreciating your presentation. Yeah, that was a great presentation. So feel free to share your question in our call chat. Felix, I'm not sure if the technical team is around. I wanted them to share more insights on the date format issue they had when they upgraded to 4.x.
Yes, our technical team is here. I don't know, Dave, do you want to say anything regarding the version upgrade and our data issues?
Yes, so I think one issue was that a formula within the X form didn't work anymore. And then we had the issue with already submitted forms when editing them. And yeah, basically we had to come up with a new formula within the X forms. And that was quite a hassle, yeah.
So I think on the version 3, we just had so many different time and date formats that were collected. And then on the version 4, it was only one format that was allowed. So all the other formats didn't work anymore, and we had to introduce all new calculates to kind of convert the other formats to the new one. Yeah.
All right. Thanks, Dave, for sharing that. I can see a question from Twitchy. Twitchy, would you like to voice that?
Yes. You mentioned that one of the challenges was the network issue. And I'm curious, like, what was the solution for that? Because I think you mentioned every week you would export data to another tool for analysis and stuff. Yeah, what was the solution for the network issue?
So, I mean, lucky enough, CHT works completely well offline. Thank you for everybody who worked on that. Otherwise, our project wouldn't have been possible. So in Lesotho, we had basically our situation was that not all the community health workers had access everywhere, but all of them had, an option to maybe walk half an hour to find connection or so. So what happened to us regularly was that we looked at the data, we didn't see the uploads, we thought that they are not working or, and then calling them and then realizing, oh no, they actually did work, but just didn't upload them. So we had to somehow start reminding them to, regularly search connection, upload, so that we could make sure that we really have the real-time monitoring. But it was feasible now in our setting, but still a bit a hassle for our community health workers to always get to somewhere when they have where they have connection.
Okay, thank you.
Good. Then there
Can
is one.
also see another question. Thank you for the presentation. Very interesting project. Given that the reading for hypertension value depends on many factors, how did you standardize that? And how do you handle clients who interrupt treatment?
So for the standardization, what we did is that at every visit, I mean, there was obviously the training in the beginning where community health workers, they were trained that, patients need to be seated and the arm position and the cuff size and all of the kind of technicalities of the BP measurement. And then every time they need to measure 3 values, and we would calculate within the X form the average of the last 2 values, like it is recommended also by the guidelines. So this was a bit our approach. I think it's not optimal. I mean, the gold standard now in many countries for BP diagnosis would be a 24-hour measurement, which we didn't have. But I guess it's already much better than what most nurses do at the facilities, where they just take one measurement and then just take this value. I think what could be a nice improvement for somebody who has more resources than us would maybe be to have an automated connection between a BP device and the application, because there is some evidence that unobserved measurements are actually more accurate than observed ones. So imagine if you could now just place the cuff, have the patient in the room, leave the room, it would automatically do the 3 measurements without somebody standing beside the person, and then this could be uploaded to the application. Obviously, this would be super nice. But in our setting now, it was 3 measurements and then manual entry into the app and automatic calculation of the average. And if somebody interrupted the treatment, as said, we obviously this problem, you always have it if you take care of people with such conditions. Nobody likes taking pills, and you have not usually you don't have symptoms, so then you always have to keep reminding patients to take the treatment. So we would just offer the treatment again based on the values that are measured that day. And then we would always ask, okay, how many days in the last 4 days did you take your treatment, so that we could estimate whether the measurement taken was taken on the treatment or not on the treatment. And then depending on this, we would reoffer the drug. If a patient was not willing to take the drug by the community health worker, then we would follow up with the referral information and say, okay, it's not a problem if you don't want the drugs from me, but then please go to the facility. And yeah, it's also a challenge. I think also very important there that you do a proper training with your community health workers so that they understand the conditions and are able to do that kind of counseling in an appropriate way.
All right. Thanks, Felix. I think there's a question from Tucci of which you can respond in the our call message tab, because we are moving to the next presentation. I think the question is, sorry, can you repeat the name of the device? Yeah, please, Felix, feel free to type your response to that. This particular, thanks, Felix, for that great presentation. I think we have learned a lot in terms of research, implementation, and also in terms of management for hypertension and diabetes. We have had even medical terms like myocardial infarction, of which we are going to research more about that. So moving on, and one exciting thing about today's roundup is the Combacal team worked closely with the Swiss TPH to build these workflows. So in our next presentation,